Thank you very much, Andre. Thank you very much for all being here. The first take my excuses that I don't speak Russian. This is a problem, obviously. Sorry for that. I will try to give the presentation in English. And as I learned, it would be a simultaneous translation. Hopefully it works the way if I need to do something else or speak more slowly or, well, just rephrase something, please tell me so. Yes, thanks again. Thanks again for the invitation to be here. I think it's a privilege for me to be at this famous institute, this world-famous institute, just from a little German neurosurgery department in Berlin. Well, I was asked to give you some opinion and on neurointensive care treatment as we are doing this. Some opinions on monitoring, with a special focus on multimodal neuromonitoring, which is my main specialty. And for this reason I prepared two talks. The first one of this is about traumatic brain injury and monitoring. The second one will be more about submarine hemorrhage. It just offered the way just to separate a little bit things to a little bit different focus. I think there's evidence for using multimodal monitoring, including ICP monitoring and brain tissue oxygenation monitoring for both signature diseases of neurosurgery. And, well, I'd like to share the slides and the course with you. Thank you very much again. If there are any questions, I think this room is rather crowded and it's a rather small community. Just interact and ask in between, so I think we will get some idea how to understand each other. If anybody needs the slides or wants to contact me, my email address is at the bottom. Feel free to drop me a mail and I'll send the slides to you. It simply did not work this morning to put this online because the server in the hotel room just denied me to upload it to Dropbox, so it's not able to do it right now, but if you need somebody of you wants to have it, it's fine. Okay, one question for you. Who of you is a neurosurgeon? Are there neurosurgeons inside you? Another one? Okay, 3, 4, 5. This is great. Who is a neurologist? Also a few. And intensivist is the majority of you. Okay, so I pretty much have this focus when preparing the slides. Just wanted to know whether I'm correct. Thank you. Okay, there's a conflict of interest statement. I'm somebody's payroll, obviously, not only my university's. Keep that in mind if you want to decide whether I'm biased or too opinionated on some things. I don't think so, but you decide on your own, please. The first talk is about traumatic brain injury. Is about current Brain Trauma Foundation guidelines and some problems attached with it. The problems with fixed ICP thresholds, how it's in the literature.
Keep it closer to your mouth.
So, sorry, thank you. Please remind me again if I'm too... okay, thank you. It's about why we need additional parameters besides ICP and CPP, cerebral perfusion pressure. It's about brain tissue oxygenation monitoring in traumatic brain injury and the relationship of brain tissue oxygenation monitoring with outcome. We start, when should we treat an ICP? Any opinion on that? When would you treat an ICP value in your department, if you're measuring it? Any idea? Any value? Just shoot. Sorry? Homer? Okay, then the number? So, there's one number written actually in the guidelines. This is magic 22 in the current guidelines. Used to be 20 some time ago. In the 2007 guidelines, in the 2016-17 guidelines published in neurosurgery in the January issue, it was 22. Well, this is one thing, but there was one study out, this is the guidelines as it is written. It is written here, treating ICP at 22 is recommended because values above this level are associated with increased mortality, meaning it leads to a better outcome. This is written in the guidelines. In a moment we'll look how this number comes from, and where this number comes from, and whether this is really solid evidence. But at first, I'd like to show you this one. This is a paper in the New England Journal of Medicine. It was a trial on intracranial pressure monitoring per se. They used the threshold of 20 to treat, and this study was a landmark trial considered to be undoable in Northern America, where the main author, Randy Chestnut, is from Seattle in Washington State, was from, so it was undoable in the US. It was not possible to do this for ethical reasons in Europe. However, the authors decided to go to some countries where there's no broad spread introduction of ICP monitoring, like in the first world. So they went to Bolivia and Ecuador and did the trial there. And what they basically did, they randomized using an ICP device in patients with traumatic brain injury and using conventional treatment with repeat CT scans, bolus mannitol, and decompressive craniectomy as a clinical thinking. And what came out was this one. There was a difference in outcome, which was not significant at the p-value, but you see here the ICP monitoring group behave a little bit better than the patients treated in the conventional way on this gray line. This was not significant. It, well, was a little bit closer in the first 14 days, but then over time it was lost. The reasons for this not being a different in outcome were manifold. It was, well, Bolivia and Ecuador has not that much rehab facilities available, so people died afterwards after initial successful treatment. It was, they have no good emergency car system available, so most of the patients came in rather late and were admitted to the ICU several hours later than it would be in Europe, would be in North America. Well, indeed, after this results, which were thought to be disappointing at first, some departments, even in the West, quitted ICP monitoring because there would be no evidence for that. But is this true? In my opinion, I don't think so. This is not a good idea to say that the ICP monitoring makes no difference. But if you look at this study more closely, you'll think that the study may just be underpowered. Let me explain this concept to you. Besides other things, I already mentioned that, there were 320 patients included. 160 patients in each arm, 160 patients in the ICP monitoring group, and this conventional treatment group by evidence, by just conventional things, 160 patients in this group. And this makes 160 patients each group. 1/3 of them was discharged from the ICU on day one. If I'm discharged from my ICU on day one after traumatic brain injury, I either do not have a severe traumatic brain injury or I'm dead. This is the other one. So there's no way that discharge being on day one contributes to the outcome. So this is just the problem with the study. There's some small difference, but the patients who truly count, they are too few in the study, and this is the reason why it doesn't show any big difference. And by the way, the waste of resources was bigger in the conventional group with this ICE monitoring, with just based on evidence, based on estimates of the clinician, than just implanting a device for 500 to 1,000 euro or 500 to $1,000 in the brain and have some monitoring for a few days. So the first group with the more invasive monitoring was cheaper and more successful, at least by numeric comparison, than over the conservative treatment. So ICP monitoring has a place in the modern ICU after traumatic brain injury. This is my thought and my opinion from this study. So let's go back to the guidelines and see where this magic number of 22 when to initiate treatment comes from. It's one study from Cambridge, UK, published here in the Neurocritical Care Journal in 2012. And they analyzed their traumatic brain injury patients from their database at Cambridge, UK, at Addenbrooke's Hospital. I've been there, very complicated building with much level and different levels and floors and elevators in between. Something like here, as I learned it for today. And they analyzed their patients according to outcome with a stepwise chi-square test. They did it once, compared the one number, so differentiation between alive and dead, and probability of being alive and being dead, and then went up all the time. This is for the PRX, the pressure reactivity index, but the same was done for the ICP to get some ideas, and saw where the maximum of the chi-square statistical test was. Well, this is a procedure which is unique in literature. This is done once in this paper, otherwise you would have maybe some receiver operator characteristics analysis or some other threshold analysis, but they did it this way, just with repeat statistical testing, which is a questionable method. But they did it this way and found out that, well, indeed there was a threshold for survival of 22 for all patients. Patients above this level had less survival and less favorable outcome than patients below this level. All values of an ICP treatment summed up together. However, there were differences, and this was omitted from the guidelines. Elderly patients do not sustain that much ICP as younger patients do. Females have a little bit different threshold than males. Patients with lower GCS, higher values than patients with upper GCS levels. So lots of different thresholds. But one value was picked up for the guidelines, and this made now famous 22 number. I think things are a little bit more complicated than that. And this is nicely shown in this paper by Fabian Düser from Leuven in Belgium. They analyzed patients from the Brain IT databases, a database from 20 centers all over Europe doing neuromonitoring, ICP monitoring, and they looked at this, whether the patients had some insult, ICP above a certain threshold level, and looked at the patients who died, Glasgow Outcome Scale 1 levels, and up to patients with good outcome, good recovery, Glasgow Outcome Scale 5 levels. They did some nicely machine learning statistics and built associations, positive meaning the particular elongation from ICP was associated with this kind of outcome, or no association, and a negative association, so meaning high ICP leads to worse outcome. This color-coded scale. What came out were these slides. These are busy, and explain it to you. This insult intensity, meaning the millimeter mercury on ICP, the maximum, and the duration of this insult. So, and if you see there's no fixed threshold of 20 or 22 or something, you can sustain a high ICP of even 30 or 25 if it's just short-lived and not too long. And you may suffer damage on the brain if the ICP is maybe 18 or even 15 and it's too long over time. This was from this database, as they understood it. The situation gave this line, so there's a differentiating between worse outcome and good outcome. This was for adults, and the same situation happened to be in children. But then the threshold was not even visible, so children with severe traumatic brain injury require an ICP treatment. Was 99 children in this database. Well, you have a serious problem being a child and having high ICP and requiring ICP monitoring at all. And this is just more like nature is. There's no fixed threshold of ICP for all ages, for all patients. So it's an individualized decision when to treat and when not. Think about that. If you're a newborn, have a blood pressure of, let's say, 80 over 40, and you fall from the cradle and have an ICP value of 20, you're almost about to herniate. If you're a young adult, 20 is probably not a big problem. Closed head injury, diffuse head injury, it's sustainable. If you're 70, 80 or even older, you may develop normal pressure hydrocephalus with an ICP of 10. So the same fixed value with 20 is the problem of all previous studies. Does not apply to all patients. So we need to individualize our treatment. And this is nicely shown in these graphs, that there's no fixed border when it's good or when it's bad. The same eventually happens, published this year in the Journal of Neurotrauma by the same group, when you look at CPP. We all know that low CPP is bad, so it shouldn't be below 60, something like that, but even 70 may be too low for all patients. Here's a good zone, but if it's too long, it's 60, 65, you may have eventually a bad outcome. The whitish fields means there's no data in the database. Looking at high ICP and high CPP, there's also a problem. Driving up just CPP every more, it helps to in a short-term way, but if it's too long, let's say 3 hours, 6 hours, 300 is the longest thing in this database, and even a CPP of 90 or 85 or 80 may be too much for these patients. Again, there's age-specific things, there's dependencies on autoregulation. I do not go into these details, but this is no fixed value that 60 is enough for all patients and 80 is too much. Maybe some patients require more, but giving too much is also a bad thing. And one more thing is one example from my own hospital. This is inherent to every monitoring from ICP, from everything else. It's a crowded picture, admittedly. But this was the situation that I think January 2016, when I was called to the ICU, and the patient here with ICP monitoring had a number of 20. The resident asked what to do. This was the then magic number when to treat ICP. Well, what to do? This is as you approach it in the middle of the night at the bedside. Looking at the ICP 20, you need to do something, at least according to current guidelines. But then have a look more closely. The EVD zeroing point is the external acoustic channel. It's about here. The drip chamber was mounted here. So no way this EVD could work, because there was a little bit of difference between them. If you look at the zeroing point, it's difficult to recognize from a just 2D picture. The transducer is about here. And I took my ruler and measured. The transducer was below the zeroing point. The drip chamber was 30 centimeters above the zeroing point of the EVD. Basically, you can get every kind of numeric misreadings if you set up your ICU just like this. There's an inherent error with everything. You may go even further, recognize that it's a rheumatic device, so this is an electric system, so what is real and what is fake. But every measurement has an inherent error, and this is inevitable. For ICPs, there are major problems. In the guidelines, there's no reference of the zeroing level of ABP and ICP. The error is therefore dependent on the probe type. If you have an EVD, the level of the ICP is, as in the picture before, sensitive to zeroing error. The CPP is correct if you measure ABP and ICP on the same level. If you have different levels for ICP and ABP monitoring and using an EVD, it's just producing numbers but not evidence and not hard science. If you have a parenchymal probe, the ICP is correct, more or less, to certain drift errors, but then the CPP, the cerebral perfusion pressure, is again sensitive to error, this time the zeroing errors of the ABP. It turns out that these kind of errors are inherent in everyday work in every ICU in the world. This is also, again, getting just fixed numbers for treatment. You need to have something more, and they have something more advanced. Looking at one trial recently, the rescue ICP study was 408 patients. They randomized decompressive craniectomy versus conservative therapy. To do this, if a patient has a traumatic brain injury with an ICP value of above 25 for 1 hour. So it was a late decompression. We are learning about decompressive craniectomy in the last lesson of today even more. I won't go into much detail of the study, which is a very important one, published last year in the New England Journal of Medicine. The outcome was that there was a difference between a surgical group treating with decompressive craniectomy and treated medically. Again, details are pending for the last speaker. difference between group is significant, but it depends how you look about on these differences. If you just do a dichotomization between good outcome and bad outcome, this was done at the lower severe disability level and the upper severe disability level in the study, was not significant anymore. If you look at subgroups, there was no equal benefit in this trial for surgery or for all. So the same threshold, 25 for more than 1 hour, led to a favorable outcome, more frequent favorable outcome in patients aged 40 years or less. In this group, the medically treated patients had way more unfavorable outcome. But then if patients get elder, there was an unfavorable outcome even predominant in the surgical group, more than the medical group. So it switched again. So the effect was not compared for all sizes, for all patients, for all ages. This is again a problem. So there's no magic number where each patient requires the same treatment. So we need to have something else. By the way, this rescue ICP trial is a class 1 evidence for ICP monitoring, the same as the Eurotherm trial for hypothermia. In this case, it was a negative evidence. Or the DCRA trials. If you don't measure ICP, you have no chance to get a good decision when to operate and when not. And ICP monitoring is about correct decision making. When to treat, whom to treat, and when, and with which method. This is the reasoning about ICP monitoring we developed over the last years. But it's not enough to measure ICP. We need to have additional parameters which may guide us in our treatment. This is a head injury patient from, again, Cambridge, UK. See a small contusion here. A little bit denser areas here on the left side of the skull. Not too much. This patient got an ICP monitoring in Cambridge, UK. It's a fascinating world. They go out of the ICU and 10 meters away, the door of the PET scanner is open. And then they took this patient to the PET scanner and measured ICP. It was 22 at the beginning. CO2 was controlled good with 35. And then they hyperventilated the patient to a PCO2 of 29. We are doing this commonly on the ICU, just by missetting the ventilator. The ICP went down as expected, so this magic number, 17 is a good number, should be preferable. But if you look at the images from the PET scanner, the ischemic brain volume here, the neurons on the opposite side from the contusion, these whitish neurons here, the oxygen extraction fraction is way above the 75, indicating this ischemic brain volume is ischemic, and it increases vastly by just hyperventilating these patients. And if the ventilator setting is to be continued this way, this ischemic brain volume is about to infarct and die. No way that this proper treatment. If I have a traumatic brain injury, at least I want to have to keep these neurons on the opposite side and not to get it wasted by just proper ICP treatment. So we need to have some monitoring about oxygenation. What do the guidelines recommend? This is Brain Trauma Foundation Guidelines 217, level 3 evidence down below. The same sheet as before. ICP monitoring is indicated in patients with severe TBI, and they recommend jugular bulb oximetry. Not the Lycox monitoring, not the aromatic oxygen monitoring, but jugular bulb oximetry. Okay. There's no other mentioning of other tools. Let's look at the evidence for that. This is current guidelines 2017. It's based on 3 papers. The oldest one is from Claudia Robertson, Houston in Texas. There's a fine study with 116 TBI patients, a cohort study, prospective observational study, low class of evidence. Well, nothing to say about that. It was one of the early adoptions of this jugular bulb oximetry. There's a small study from Philadelphia, Peter Leroux's group, 32 patients, and there's this big prospective controlled trial of 350 patients from Julio Cruz. This is the main evidence for that. Let's look in this major paper, the work of Dr. Cruz. Sounds compelling, large number of patients, prospective setting, interventional study. Well, let's see. First question when you read this kind of papers is, where did this happen? And the only thing the paper states, it was a university hospital. Don't know which country, don't know which city, So it's not study anymore. It was a prospective interventional study, but what was the allocation strategy? When was a patient given the new device, this jugular bulb oximetry, and when was the patient just allocated a conventional treatment? We don't know that. Let's look at the patients. They are sick patients. There's young patients with ICP values of 33 and 31 in both groups. So this is mortality way higher than rescue ICP, which was 50% in the conservative arm, and it was even 20 years before. So these are quite sick patients. However, their outcome surprisingly good. The CPP group, vegetative and state or dead, 56%. This is to be expected with the sick population, but then only 12% mortality in patients treated according to the oxygen strategy in this new device. This is fascinating. Imagine you're decreasing from 100 patients a mortality of 30% to 12%. This is next to impossible, at least in current times. And I have my doubt it was in 1998. So if you want to ask the author a little bit more about details of the patients, how they treated them, look at this post box in Sao Paulo, Brazil. Nothing else. No institute affiliated with the author, so it's questionable. And the very same author was questioned for other studies, for studies on mannitol. And this was from people from the Cochrane Institute doing controlled reviews for evidence for other studies. Well, they inquired, they pressured, and then the main author, Dr. Cruz, committed suicide. So it's most likely that there's a problem attached with it. And they told us, the authors, it's written in the paper in the British Medical Journal 2007, that they are left with serious doubts about important studies, but no way of determining whether the confidence is real and the results are real or fabricated. The main author is dead. There's no institution to investigate. The implications from these kind of studies, from this fake science, is serious. The patients are treated on the basis of potentially unreliable evidence. And the same, unfortunately, happens for this paper on jugular bulb oximetry. It's most likely fabricated. So this is the current evidence in the guidelines. No way we can build some evidence and some recommendations on that. Furthermore, the guidelines omitted something. This was work from Berlin before the time I was here at the same university, but it's the same ICU, just newly built now. And they found this jugular bulb oximetry had a time of good data quality of about roughly 50% at best, where the new method, oxygen monitoring with microprobes in the brain, was reliable for most of the time, 95% in the study. And I think it's increasing over time even more. So let's look at this new thing, this brain tissue oxygenation monitoring. In the market since about 95, there was the first probes available. This was then the LICOC system. In 2006, a new system, the Rometic system here, was available in the market. And they both more or less measure the same. I'll show you some comparison slides in the next talk as well. What can we do with that? This is a correlation of brain tissue oxygenation with the regional cerebral blood flow measured with a blood flow probe from Hemenix. This is an animal experiment. You see it's going this S-shaped curve, like a Lassen curve. The cerebral blood flow also increases brain tissue oxygenation. These were two swines. In fact, swine 1 is here, swine 1 is 2. If you normalize to the middle values, you see this S-shaped curve nicely with a very high correlation. This is animal model. In humans, it looks like this. You have the CPP, which is known, shouldn't be below 60, maybe something between 60 and 80. If you look at the CPP, with each CPP level, there's an independent association with brain tissue oxygenation. There's, of course, a mathematical relationship between both parameters, but then this is not to be predicted whether CPP of 60 leads to low brain tissue oxygenation of 10 or adequate brain tissue oxygenation of 20. This is the relationship it is, so you need to measure both parameters to have an idea of what's going on. This is the way how we understand now brain tissue oxygenation, the cerebral blood flow, and the product of the difference between arterial and venous partial pressure of oxygen. This product is here the brain tissue oxygenation. So anything CBF increases more blood flow, leads to a higher reading. More arterial oxygen, like setting up the knob on the ventilator to 100%, gives you a higher reading, and more demand for and more oxygen, let's say during a seizure, more extraction of the oxygen leads to lower values. And this relationship is quite workable. It's difficult to visualize, difficult to understand, but then you can work this on the ICU. And there's some nice work being outside. The position of the probe is important as well. Okay. This is an animal experiment by the same group from San Francisco. They did a cortical impact injury in a swine model, planted one of the oxygen probes directly inside the injury, one at the rim of the contusion, one a little bit remote in healthy brain tissue, and one on the contralateral side. And the readings from this oxygen probe, to be understood correctly, behave as it would be expected. This is a baseline reading of ICP, so if you hyperventilate, let's say increase CO2, ICP goes up. If you hyperventilate, CO2 goes down. The same for oxygen. If you do a little bit hypoventilation, oxygen goes up in the more remote probes, and oxygen goes down at the rim of the contusion, this probe, and these about the same at the very low level inside the contusion. There's no blood flow anymore inside the contusion. There's just a residual remnant of oxygen residing here. If you hyperventilate, removing CO2, constricting the vessels, oxygen goes down again and goes further down inside the contused, at the rim of the contused area. Same at an FiO2 of 0.1, room air, or 100% oxygen here. And if you look at the probe position, farthest away, you do an oxygen challenge. Oxygen on the probe just stays low. If it's room air, and goes up to a very wide spread if it's 100% of oxygen. And this difference shrinks if you're moving closer to the contusion, at the rim of the contusion here. So there's a little bit more scatter on these values. And if you're inside the contusion, there's no big change in the brain tissue oxygenation, but only in the arterial oxygenation. This is the way how the probe behaves in the animal experiment. And this is how it's done in humans. Big study from Houston again. It's Claudia Robertson's group. Patients with traumatic brain injury. It was a huge study of about 400 patients over time, so it was not prospective, it was collected prospectively, but it was not with intention to treat in mind. So they had probes placed in normal brain, give a normal reading of about 25, over time pretty stable. This is the time after admission. The values are lower if it's under an evacuated subdural hematoma, so it's about 20. So this is the now known threshold when we should treat and try to treat it. If it's near or inside contusions, it's near the contusions, it's even lower, goes down, and then gets up to the 20 level after some hours, and it stays prolonged time in a low level in the contused brain values. If you're doing this kind of analysis in a huge number of patients, you can do this multivariately, you can do some differential considerations. Brain tissue oxygenation and outcome, favorable outcome, meaning classical outcome scale of 3 to 5 versus 1 to 2, means is age-dependent. Elderly people do have worse prognosis, we know that, this is common. But even if you correct for that, and if you look at that, the catheter position matters, whether it's in normal brain, being either uncontused areas or underneath an evacuated hematoma, but otherwise normal, or it's an abnormal brain. It matters how long the time readings of brain tissue oxygenation are compromised, whether below 20, the current threshold, or more conservative below 15 or even below 10. There's always significant results if you look at this interaction between variables. The catheter position between normal and abnormal brain is put here, and this is the timing. So if the patient does stay on the same level, it's worse than the patient just increasing over time. Well, this is a nice study where we learned how to place the probe in the injury zone, at the tissue at risk. And this is the way the probe should be placed in traumatic brain injury. What is the accuracy of this kind of multimodal neuromonitoring to detect hyperperfusion? Well, this is a small study from Switzerland, from Lausanne, from Mauro Otto's group. They had trauma patients, had an oxygen probe placed on the right forebrain, and did a CT perfusion scan. Looked at the global CBF and the regional CBF, just drawing regions of interest if it's drawn in normal brain. I think it's pretty good correlation in the CT perfusion, so it's the same, about the same. Looking at the values from the brain tissue oxygenation, you can decide between a low CBF reading and a normal CBF reading. With significance, these are lower readings, it's 20, 21 for the oxygen probe. For low oxygen, and 27 is just a normal cerebral blood flow reading. There's also significant difference in microdialysis. They put a microdialysis probe in the same area of vicinity of the probe as well. And there's also some difference in the ICP readings and the number of high ICP episodes. The average ICP, which most studies so far looked at, was 15 versus 12. So the average values do not count. It counts as the maximum values and the time spent about maximum treatment. So if you add to standard ICP treatment another modality, either brain tissue donation or microdialysis, you're getting this receiver-operator heuristic curves. This is the chance of being equal. ICP monitoring gives you more information for the patient. This is the area in the ROC curve of 7.4. And if you add another monitoring modality, either brain tissue donation or cerebral microdialysis, you get more information. If we combine each three of them, ICP, brain tissue donation, and cerebral, it's even more information, but it's no significant difference. The same level of confidence confidence interval is about the same. But then, brain tissue oxygenation versus ICP monitoring alone, this makes a difference. One reason to add one other probe. Looking at outcome after traumatic brain injury before and after introduction of brain tissue donation monitoring is this slide. Philadelphia, Peter Leroux's group, published in 2010. In 2002, they just introduced brain tissue oxygenation monitoring in their strategy for traumatic brain injury. And with the new strategy, they had less mortality and more favorable outcome. This was historic controls, was before 2002 and after 2002. So most likely it's not only the brain tissue oxygenation monitoring, this is the same with all historic studies, with all historic control studies. A new team took over with a fresh spirit, fresh-minded air, with dedicated intensivists, and they also introduced brain tissue oxygenation monitoring. So the combined effort of all as a bundle makes the difference. This makes these kind of meta-analysis a little bit questionable if you work with historic controls. But fortunately, now there's a prospective randomized controlled trial on brain tissue oxygenation, which is the BOOST 2 trial. They had patients with traumatic brain injury in 10 centers across North America. GCS level of 3 to 8 means severely indicated unconscious patients requiring intubation, which are the candidates for additional neuromonitoring, and they considered each patient to have a requirement for ICP monitoring. However, both groups received ICP monitoring and a brain tissue oxygenation probe. The intervention group recorded ICP values and oxygen values and did their therapy according to both of them. ICP below 20, brain tissue oxygenation above 20. This was randomized versus a plain control group, again with both kind of probes, but therapy only to ICP values. The physician at the bedside was blinded for the brain tissue oxygenation probes. That was the difference between the first ICP study from Randy Chestnut, you remember that, this big New England Journal of Medicine paper, where only the intervention group got the ICP monitoring, the control group got nothing. Here both groups got both of them. And now let's look for the difference. The primary outcome parameter was the time of brain tissue oxygenation below 20. Seen here, this is a numeric slide, a little bit difficult to read, but I'll walk you through. The proportion of time below 20 in the ICP only group, well, for the oxygen, 44% versus 15%. Significant difference. It was average depth from this 20 millimeter mercury margin, also deeper in the conservative group with only ICP monitoring. And also the ICP monitoring proportion of time above 20 was in favor of the oxygen group. So this time it was lower, the brain tissue oxygenation and ICP combined probe. This was a significant result. What was not significant, but shows still a nice visual difference, is the Glasgow outcome scale extended at 6 months. This is the proportion of people being dead, 25 in the combined group versus 34% in the ICP-only group. So it was a tendency to better outcome all over. It was not significant between groups, but still it's a good tendency in a rather small group of 110 patients. And this is good evidence for building additional treatment with brain tissue oxygenation. And now this is run as boost-free trial in North America. So about the traumatic brain injury and monitoring and current evidence. If you like to sum up, the brain tissue oxygenation and the ICP are both outcome relevant after traumatic brain injury. There's unfortunately only weak evidence behind current brain trauma foundation guidelines, and sometimes this evidence is just misguided and misinterpreted, as I showed you. The brain tissue oxygenation offers the opportunity of individualizing treatment, whether a patient needs more aggressive treatment or just can stick with the ICP of 18, 19, 20 and everything is fine, just wait some time. The data for brain tissue oxygenation is more robust from other monitoring tools. I'm not going into details into this short lesson for near-infrared spectroscopy or cerebral blood flow monitoring or even jugular bulb oximetry. The goals, ICP should be below 20, the new margin 22, 23. In my opinion, it's just a little bit too opinionated and too ambitious. 20 is easy to memorize. I'm sticking with this value. The same values, 20 millimeter mercury, is taught to the residents that these values should not be above, and in the case of brain tumor should not be below 20 millimeter mercury. Some practical tips if you introduce neuromonitoring and consider data from neuromonitoring though. Which patients which you should monitor? Severely traumatic brain injury patients, severely affected, which are salvable. It's no use to use this advanced monitoring in patients who are awake and you can talk to them. It's also no use if both pupils are blown and they're wide and the GCA is free over time and there's no surgical option, so there's no use to introduce monitoring these kind of patients. You need to consider only those who are just who have something to lose. But if you think this patient is treatable and you want to treat him for traumatic brain injury, I think I wouldn't place no age limitation, I wouldn't do anything, I would just go forward with both monitoring methodologies. Keep in mind that not every patient is salvable. And not every low reading leads to a worse outcome. Sometimes it's frustrating to see numbers which are difficult to correct. And keep in mind that outcome effects are difficult to see and most likely lower than anticipated. Which means if you're treating 100 patients with a mortality of, let's say, 30%, to go to 25% or 20% makes a huge difference for some families. But it's very difficult to see this as individual physician treating a single patient. So keep on going and persuade and try to do a good work in every patient. Thank you very much for the first one.